In this episode of our podcast, we are joined by thoracic surgeon and surgical oncologist Dr. Donna Maziak and nurse navigator Chantal Bournet from the Ottawa Hospital, one of the centres performing lung cancer screening in Ontario. Hope you enjoy it. So Chantal and Dr. Maziak, welcome, and thanks so much for joining us virtually from the Ottawa Hospital. In your opinion, I'm wondering for the both of you, what are the greatest unmet needs for patients with lung cancer?
Well, as a physician's point of view, this is an extremely broad question. There's a lot of needs. We underwent cancer transformation in 2012. We're doing it again now to meet the needs of these lung cancer patients. One thing that we weren't really doing is having a screening program, which is the biggest thing and change. As of April 1st of this year, we now have an official screening program like you have in breast and in prostate and colorectal, which will make a huge difference. Other needs I think that aren't met for these patients is the ability to have it in a timely fashion closer to home. A lot of these patients, it's very subspecialized treatments, very subspecialized testing and biopsies that aren't necessarily done at home. And they, would prefer to have it closer. It can be quite difficult as it's an older population compared to other cancers. Very difficult with all the multiple trips, whether it's for treatment or whether it's for investigations. With cancer transformation, we did try to have a navigation day with 1 day shopping. But nevertheless, there's always a couple that aren't always done at the same time. And I think also their overall needs with comprehending, having a go-to number specifically to try and meet all their needs every day. Getting a diagnosis of cancer is a huge burden on a person, especially if they're not familiar with the intricacies of the hospital runnings, be it closer to home or at the Ottawa Hospital. And I think, we need to work harder on that. We've worked at the top part. Screening is to try and prevent them from getting there. But now we still have other needs of these lung cancer patients. The other thing, too, is there are certain hotspots in the area we cover, and it still makes it quite difficult for them to access the needs and also to access a family doctor in order to start the process. And there is a big shortage of family doctors, especially in certain areas. And the family doctors are great at getting the patient in, but if the patients can't find a family doctor or start the whole process, often they're waiting late to present. So that's another factor that would help with early detection.
So Chantal, maybe you can talk a little bit more about specifically what Dr. Maziak mentioned about early detection. How important is that?
Well, I think it's key to changing the lung cancer narrative. The typical story is that the patient presents to their family physician or to an emergency room with some symptoms of lung cancer, and sadly they're diagnosed at an advanced stage when there are limited options. So I think early detection offers people a lot more options in terms of treatment and hope to have a better outcome. But I think even beyond that, just to build on what Dr. Maziak was saying, I think one of the big unmet needs for patients with lung cancer and who may potentially have lung cancer is the stigma associated with that. There's stigma associated with lung cancer, in particular, because people will assume that because you have lung cancer, you must have caused that due to smoking. And that's really unfortunate. No one sets out to give themselves a life-threatening disease ever. We're starting to find more and more people, especially women, who have never smoked cigarettes and they're having lung cancer. And yet, often the first question people are asked is, well, do you smoke or have you smoked? So there's a lot of stigma and people are reluctant to come forward. Some people are reluctant to go and see their physician because they automatically assume there's going to be that judgment.
I mean, keep in mind, of those who get non-small cell lung cancer, only 85% are smokers. And of those people who smoke, only 23% get lung cancer. I mean, they're busy, they're not getting lung cancer, getting, coronary disease, stroke, peripheral vascular disease, other cancers. But just to give you an idea, it plays a great contribution, not only to lung cancer, but to the overall health of a patient in society, and the overall burden to the healthcare system is this smoking thing.
talking about that, how do you define a patient who is at high risk for lung cancer, and how can this early detection be assessed?
Well, for our study, we have a specific definition and a specific entry point. And that was through using numbers and creating a formula to be able to detect your risk of developing cancer in the next six years to be 2% or greater. And that allowed you to participate in the pilot study. And now we're carrying it over into the program. Time may change that. Like with breast cancer, they have different criteria now of when you should start and stop and everything. And this is a new program, so that may change. Right now, though, to enter into a screening program, you have to be between the ages of 55 and 74, and you have to, before your 75th birthday, and you have to be a smoker, a 20-pack year smoker in some way. And you then present yourself or through your GP. If you don't have a GP, we will get you one because of other things that may happen. And there's then questions that are asked, and questions like your weight, level of education, other risk factors, and then they calculate your score. And as long as your score is 2% or greater chance of getting lung cancer in the next 6 years, you can participate in the screening program. Otherwise, you're not considered high risk. So that's what the definition is now for this specific program, but it may change in the next 10 years. It has its limitations. We still, based on the pilot, don't have long-term data to see what it is. The other thing, too, is even with the big studies like the Nelson study and the NSLT study, we don't have actually stop dates. It doesn't say, well, at 85 you should stop, or at 83 you should stop. So that's another important thing with the program being something in its infancy. And also, you do miss other people who have a much higher smoking risk because of the age cutoff. Chantal can speak to that. There's a whole patient population we're missing because of that.
Yeah. I think you're referring to our Indigenous population, where we know that our Indigenous population, so First Nation, Inuit, and Métis, typically live shorter lifespans than the average Canadian. In fact, I believe for the Inuit, the average lifespan is about 72 years. So well inside of our inclusion criteria for this program. And unfortunately, we're not able to start assessing them for risk of lung cancer at an earlier age as yet. We're hopeful that that will change in the future, but that is definitely a limitation, and the rates of the rates of lung cancer in these populations are much higher than the rates for average Canadians. So it's certainly an area that we need to look at in more detail in the coming years.
I mean, we cover the BAFFIN program, up north in Iqaluit in that area, which has the highest incidence of smoking in the world at 67%, whereas overall smoking incidence in Canada varies from province to province, but it's all around 19 to 20%. So that has the highest incidence. And so we sort of fall short in that area just because of these criteria, which are, of course, are, averages. I'm hoping with time that will change.
How did these programs actually start, and in the pilot program? Can you just take us through the history a little bit of that?
It was actually a very interesting history. I'm glad you asked that. There was finally, I was working a lot with the group to try and get the federal government interested, because the provincial government wasn't interested in the screening program, which was already established in BC. And then, kept bugging CCO, and eventually CCO decided to take it on. And we had to put in a plea, created a document of what we thought would be a good screening idea for a screening program. So there's about 15 different centers that put in a bid, and 3 centers got accepted. What sold them on our center is we provided a tri-center approach so that you would get out of the downtown cores and you'd get other patient populations. So in our study, we actually had 3 CT scan machines. We had Cornwall, the Ottawa at the Riverside campus, and Renfrew. So it allowed us to see how things work in the periphery, not just downtown, expand the population, and also hopefully to reach the Indigenous population. And the 3 centers started and went through the whole thing. Chantal, did you notice any difference in the smoking cessation that goes along with it at the different centers?
Yeah. Certainly, I would say that although the numbers in the urban center in Ottawa, just the sheer number of patients is much higher, but the rates of people who are smoking in the rural areas in Renfrew and Cornwall are significantly higher than our urban population. So, one of the key components of a screening program is to offer smoking cessation. Prevention is always your best medicine. So it is something that we as navigators take very seriously, and every person who smokes in this pilot at every contact that this pilot now the program, at every contact we are talking and asking about their smoking status and are they interested in becoming smoke-free. We automatically assume yes. We use what's called an opt-out model. And that is where we assume that people want to become smoke-free and they need to tell us that that's not the case. So that otherwise we intervene and we offer assistance, and that may be full smoking cessation consults with one of the navigators. We may be referring them to other local programs. We may refer them to Telehealth Ontario's smoking cessation team if they're just looking for a little bit of information and maybe not quite ready yet. So we try to meet the patient where they're at and offer the resources that meets that need.
Speaking of lessons learned, what other types of lessons did you take from the pilot before it became a program?
So as long as you get in, you get a low-dose CT scan, it's reviewed by a radiologist, it's given a number, and depending on the number, you get a repeat CT scan, usually in a year, but if there's any problems, you then go down another pathway, or you may get a short-term follow-up. But the original pilot said you had to review the scan and give the patient the results in 45 minutes. That was the criteria. We said, well, could we call them? Could we let them know? No, and all this stuff. And what we found was, even though we said, okay, we'll really try to do this, and it's harder also for the people in the periphery to do these low-dose CT scans, because if you want to give the report in 45 minutes, you always have to have a radiologist on site. And especially in the smaller centers, it was easier for them to do the CT scans at night, but you can't have a radiologist on site necessarily in the smaller centers. So it was quite difficult, and they may have urgent CT scans. And we were always trying to do this, and then the patients kept wouldn't wait. They thought 45 minutes was too long to the wait. And they said, look, I don't mind, call me in 2 weeks. As long as you told them you were going to call them, they didn't mind, which was a huge shock to the powers that be, that, well, the patient has to know right away. And they didn't mind. They're like, well, I'm paying for parking. Like, the faster I get out, the better it is, the less I'm spending. And I think that was surprising to a lot of people, because we kept telling them, they get the results quickly. It is a screening program. We thought it was reasonable. So that was, I think, was one of the biggest surprises. We also found a lot of what we call incidentalomas, like picking up other things, be it coronary disease, be it kidney mass, things like that, which were asymptomatic. And I think, too, the biggest surprise I had was that people did, because the importance, as Chantal said, was the smoking cessation, right? And people did accept that having a great CT scan doesn't mean it gives you another license to smoke for another year. They did really want to quit. And it wasn't a license to keep smoking because you passed this year.
Yeah, I would agree. I think it gave people a pathway or an opportunity to address something that had always been in the back of their mind. I mean, even just mentioning the words lung cancer is, it's really upsetting for people. It causes great anxiety because of the typical narrative that goes with it. And I think it was an opportunity for people to talk about their smoking and how they'd like to see that change with somebody that was non-judgmental, that, in an arena that it went together. Whereas maybe it's more difficult to set up an appointment with your family physician. Maybe you have to wait, or maybe you have more urgent things that need to be dealt with. Whereas you're coming in to see for a screening, and it fits nicely with your screening. The nurse navigator has set time aside to actually deal with this with you. We had nice, private, quiet offices. So I think the opportunity just for the patient to address it was really important.
And I think, Chantal, and you can speak to this better than me, I think it helped get rid of the stigma associated with smokers. Compared to the other cancers, people who get lung cancer, they're always felt, oh, well, it's my fault, I smoked.
Mm-hmm.
Even I remember talking to, one of the patients, the daughter. She says, no one's, I tell everyone my mom's dying of lung cancer, and no one feels bad about it. They think, well, she smoked, she's dying. Well, it's to be expected. So I really think the program helped get, that this group that's been neglected and been felt to have, oh, you smoked, therefore, of course you have lung cancer. I think it's adding some sort of class to this and raising it up that, yes, maybe at the time no one knew about this, and the whole story of cigarette smoking. And I think it's giving something to a population and a group that have always been forgotten and neglected and stigmatized. And I think it's about time that it's up in the forefront of people's minds that there is something. We need to do something. And as society, it behooves us to take care of people.
Looking at the programs themselves, so what would you say to a GP, let's say, who's interested in discussing this with one of their patients? What centers exist to do this? And then also, if they're not near one, then what would you advise?
So the original 3 centers, there was Ottawa with our hub and spoke model of Cornwall and Renfrew, and then the downtown core at the Riverside. We also started with Health Sciences North in Sudbury, which kind of covered Northwest Ontario, as well as Lake Ridge near Oshawa. So those were the 3 original centers. We added UHN, or I should say Ontario Health added UHN, probably about a year and a half after the start. So that was downtown Toronto. We're still limited to those 4 centers right now. Hopefully, with time, we're going to add more centers. I think it's certainly been my experience that when screening is important enough to the patient, that they make the trip. I mean, we've had people driving 3-4 hours, and coming from other centers and transferring. They'll come and stay with children in Ottawa to have access, even though they live quite a ways away. So I think if it's important enough now, in terms of the GP talking with the patient, I often find myself saying to people who are quite nervous and anxious about it that this is really like breast cancer screening, except we are only screening high-risk people. But the idea is to find something, find it early. And, most of the time, we're just repeating scans. We're just keeping an eye on things. And I think that helps people to really understand and situate what we're trying to accomplish here.
So in terms of the GP's awareness, are there any resources that exist currently to increase their awareness about these programs?
Well, we did distribute at the beginning for the pilot study a lot of stuff. I was doing some radio blitzes and stuff like that. So the next step is there's a big poster on the 417. Apparently for cancer, you can get a 2-month free advertisement. So that's one of the steps we want to do. But, the forms are available. We've been doing yearly presentations to the GPs, having CMEs about it during the pilot so that it's out there. And there is a form online they can have access to. There's a form also to leave in your office. A lot of the GPs who were sending people, especially now with the electronic files, they could just query their files and see which patients met the criteria, let's say for a 20-pack year between 55 and 74, and they got a list of names, and they could distribute it to them personally. So that would make it easy as well, especially with the electronic files now.
And along with that, there's Cancer Care Ontario's website has resources for physicians. The Ottawa Hospital website has, if you search for lung cancer screening, you're going to come to our website, and there is a specific section for family physician resources. And I would also add to that the screening team themselves. I mean, myself and my colleagues, we are great resources. We know this program inside and out. We're here to help. We're here to answer questions, both patients and their providers.
And it's a screening program too, where the patients can also refer themselves. And then also if they do have a GP, we'll make sure they're kept in the loop. If they don't, we do assign them a GP and try to help them find a GP, which is important, not just for this, but for everything in general.
So if you're a GP, can you just walk me through the process of identifying the patient and then referring them and so on?
Basically, they have to be between the ages of 55 and 74, and they have to have had some combination of a 20-pack year smoking, and they have to be willing to participate with low-dose CT scans, and then refer them. Then there is a triage that goes through the information, goes through what it entails, and then they have to meet the criteria, asking questions like level of education. All these things give you points. And then as long as your risk is 2% or greater of developing lung cancer over the next 6 years, you qualify. You'll first start with the low-dose CT scan, the first one. You'll meet the nurse navigator. If you're a current smoker, they'll go over about smoking cessation, and before that, they go over what it entails. You're then, the CT scan is reviewed by a radiologist. We use the lung RAD scoring system, which is a different scoring system that's just to see how many little changes are and all this. And if there's anything that is found unexpectedly, it goes to the family doctor. Because we can't, let's say they find something on your thyroid, we can't be taking care of everything. And depending on your score, you automatically, and it's when you sign this consent, you're allowing us to keep ordering CT scans. That's all you're allowing us to do. So you may go for, okay, see you again in a year for your CT scan, or maybe 6 months. It may be 3 months, or you may be referred to a diagnostic assessment center or a cancer assessment clinic, which may have, because there's something, you may need a little bit more. You may need to meet with a respirologist or a thoracic surgeon, or we have had cases where they do find cancer, and you have to start that whole process.
And there's a couple of things couple of situations where a patient should not be referred to as screening programs. So just for example, if the patient already has lung nodules that are being followed, that's not appropriate for screening. There's already something there that is being looked at. If a patient is having hemoptysis, that needs to be investigated with hemoptysis of an unknown cause. And a patient who has lost more than 5 kilograms in the past year, that needs to be investigated. Sometimes we do talk with patients who turn out to have those exclusion criteria, and we end up speaking with the physician. And then sometimes we have patients where, they may have cough, new or worsening cough or chest pain, and they don't actually qualify for the screening program, and they're a little bit confused, but my doctor's sending me here for a CAT scan. Well, I think it's important to differentiate between a patient who needs screening and a patient who may need a diagnostic scan. So I think that's something important to keep in mind as well.
And just one other thing I think to add, Chantal, is if you have a previous history of having had a lung cancer,
that's correct.
In the screening program, you should just be your usual follow-up that you have, either be it active follow-up or in survivorship.
Something else I think as well that is important for family physicians to know is that once your patient's in the program, it's really important to keep in touch with the screening program if things change with your patient. So for example, if your patient's diagnosed with metastatic colon cancer and is in end-of-life care, that's really important to let us know. I mean, we're planning for at least annual CAT scans, and we don't want to send your patient for a screening scan if it's not an appropriate thing. So I think it's important to keep in mind, is my patient still appropriate for screening? Is this still in the patient's best interest? And just keep in contact with us and let us know.
And with COVID, it's made it a little more difficult, the program. We had to, during the study, the pilot, before it became a program, we had to put it on hold because of COVID. There was, resources had to be allocated. So we couldn't do just screening CT scans. So that made patients a little more anxious when they're about to do for their CT scan. And also with the isolation and everything and the lack of being able to do a lot of stuff, the rates of smoking went up, that's for sure. And Chantal can talk more about that. But I mean, it made quitting smoking much more difficult.
For sure. Yeah, I think you're right. The isolation, the mental health issues that went along with that isolation, a lot of people found the boredom and the lack of anything to do as a big trigger to smoke, and just the stress of the pandemic in general, whether it be financial stress, mental health, whatnot. we did talk to a lot of people this past year who have returned to smoking, some of them after many years. They just didn't have any other outlet to deal with the issues that went along with the pandemic. So we've done a lot of work with people. There's most of the people who've returned to smoking are interested in making another attempt, and that's really important. The fact that people want to continue to try despite having relapsed to smoking, that's okay. Life happens, and that's okay. We're going to meet you wherever you're at, and we're going to help you wherever you're at.
Yeah, and when people are talking with you, Chantal, about the program, is there anything that you need to convey about any risks, health risks in terms of the CT scans and so on?
Yeah, there's a few different risks associated with screenings. So, one of the things is false alarms. And we see this a lot with the very first scan, the baseline scan, where there is no previous CT scan for the radiologist to compare to. We do have a lot of people with benign lung nodules in our region for various reasons. So when you do that first CT scan, sometimes people are told they need to come back in 6 or 3 months to have a repeat scan, and that the wording we use is that it has either a low chance or it might have a chance of becoming or being cancer, which is quite anxiety provoking, as I'm sure you can imagine. And frequently, when we repeat that scan, we're going to a 1-year follow-up, which is the minimum recommendation right now, is at minimum a 1-year follow-up scan. So that can create a lot of anxiety and worry for people. Dr. Masiak mentioned as well, some people are being sent to the diagnostic assessment program where they may need to undergo diagnostic testing, and I'll leave that to her to talk about. But that process is anxiety provoking, and lots of questions from people when that happens. The scan itself has some radiation associated with it, right? And as I mentioned, it's an annual scan that's recommended at minimum. And some people are having more than an annual scan because of the findings. So that can also raise, your risk of having cancer and whatnot. Now, that's part of the reason we do that risk stratification and determine whether you're high risk or not, because we want to make sure that we're not exposing people who are at low risk. We don't always find lung cancer at an early stage in a screening scan. Not everybody coming through screening has symptoms of lung cancer, and we do sometimes find advanced cancers. So, in that case, screening may not have improved that person's life, except to have found it earlier than it would have otherwise been found. There's a couple of other things, there are some types of lung cancer that grow quite slowly. Perhaps if you're, 74, something else, maybe your cause of death aside from lung cancer, but we'll find it early and we're going to treat it as though it is a more aggressive type. Those are the main ones.
Any sense about when results of the pilot program might be released?
Yeah, it should be within this year to come out and publish.
I guess the last thing I want to ask is just really, what is your takeaway for GPs listening to this episode?
I think the most important thing is that, first of all, it's a program in its infancy. Secondly, it's a high risk, although it's called the Ontario lung cancer screening program, it's actually for high risk. So it's different than breast where you just send everybody. So I think it's important for them. I'd rather them err on sending everybody than not sending anybody. But to make sure that they tell their patients, okay, I'm going to send you, we'll see if you need it or not, and they'll calculate your risk and see if you're going ahead, not to automatically say that you will get a scan. That's the big thing. And I think just because they may not meet the criteria right now, maybe once they're, they feel that, well, they're 53, they're already smoked 40 pack here. Yeah, well, that's still, I agree with them. They're probably very high risk, but they're not part of the screening program. Wouldn't you say, Chantal, just to make sure?
Yeah, I would echo that. I think, with the issues that physicians have had with the program so far, it typically comes out of that risk stratification because they don't understand that there is that secondary step in lung cancer screening that isn't in other screening programs where it's just strictly an age cutoff kind of thing. Yeah, I think that's been a great source of frustration for a lot of family physicians when their patient hasn't qualified and or they've been applying, other criteria such as from the NLST, thinking that the patient should be included. we would love to include everyone, but right now we don't have that luxury. And I echo Dr. Maziak. I think refer the patient until we go through that risk stratification process. We don't know. And I am frequently surprised when patients are answering the questions that go with that, who qualifies and who doesn't.
Chantal, would you be able to give us an idea of the number of patients that are referred and those that are actually are qualified to go into the program and accept to be in the program?
We receive here in our region, and the pandemic has really impacted on this quite a bit, but I would say pre-pandemic, we were receiving about 50 referrals a week, and these are just very rough numbers. And I would say roughly 2/3 of the patients that were referred or self-referred were eligible. And of the patients who were eligible and offered to participate in screening, it's a very unusual thing for a patient at that point to say no, thank you.
And we ended up being the largest center of recruitment for the pilot study. So I think the results will show, a good representation of the population. And the other thing, I think is more important, like Chantal was stressing, is the importance of smoking cessation, not only for lung cancer, but for all the other diseases it causes and the impact it has on the healthcare system.
We all know the effect of lung cancer, that cause and effect of smoking in lung cancer. I think that's well established. Certainly, one of the things that we look for is a family history and your first degree relatives of lung cancer. So if we can get rid of that in this generation, then the next generation following, the lung cancer rates will keep dropping off if we can stop that cycle of smoking.
And there's a lot of studies too that show that people who are non-smokers, going through radiation and chemotherapy do a lot better as well, with better results and better outcomes than people that continue to smoke. So there's always an opportunity to quit smoking. It's not like, it's too late. It's never too late.
It is never too late.
There's been so many advancements in chemotherapy. So there's a lot of, genetic testing being done, looking for specific mutations to have specific drugs to go against these. So it's a vastly expanding field. And so even the early stages, we're improving the survival in those early stages, because early stages, it's not 100% survival. Survivals that are comparable to the survivors that you see with early stage in breast cancer and prostate cancer.
Well, that's a really hopeful message, I think for these patients and for the listeners as well. And some excellent points. Is there anything else either of you would like to add?
There's one other thing I would like to add, just following up on the smoking cessation theme. I think for a lot of people, the big barrier is cost, right? Most of these products are very expensive, nicotine replacement over the counter, the prescription options are very expensive. So I think if you can include in there that there are plenty of programs that will cover the cost of those products, and some of them for up to 6 months. So it does not need to be a barrier. I've had people in tears because they didn't realize that help was out there.
I think also that to encourage them that some people take, the first shot they can quit, other people take multiple tries. And the important thing is they keep trying.
I really thank the both of you for taking part today. And I hope to see more of these programs pop up, with the success of yours.
And the important thing is to the GPs, keep referring.
Yeah, thank you both so much. It's been wonderful.
Thank you, Anna.
Thank you.